here. I'm the volunteer director of Affiliated Support Group Affairs for United Ostomy Association. And I am so excited for tonight. It's going to be so much fun. This is put on by the United Ostomy Association and powered by 11 Health. Thank you. My goodness, we needed their help with technology, and this is so much for us to learn about. It's so fun to have you here. It's amazing to think that we're able to reach so many people here tonight through the latest technology. I'm also a person living with an ostomy since 1995, and Google wasn't even invented until 1998. So that tells you why people my age are getting excited when we can successfully connect to Zoom or webinars. So if you're one of those people who just went through panicking, I get it. We've come a long way since we were thrilled by solar calculators. So you see what I'm talking about here. So I was diagnosed with colorectal cancer in 1995. My kids were 3 and 5 years old, and I had been married only 6 years at that time. And to my horror, I found out I would need to have a permanent colostomy and all that that would entail. It was necessary for survival and to see my kids grow up. So now that they're grown adults, and so far I have 2 grandchildren, and that husband is still hanging in there with me for 32 years so far, I jokingly say that when they removed my rectum, it gave me more room for creativity. See? Little did I know that having an ostomy would lead me to a path of stand-up comedy, nationally speaking, and even being an author of 5 books. And now I get to MC this special event, the debut of the Ostomy Academy. My ostomy was not only life-saving, but life-enhancing. And so, because I got to meet so many wonderful people across the USA and Canada because of having an ostomy, I shall always be grateful for all the things that people have shared with me over the years. And that's why I believe the Ostomy Academy is so important for all of us. Let's hear about what's happening tonight. So we have great presentations ahead of us tonight with Dr. Rob Fern talking about hydration, WOCN and registered dietitian Judy Madura talking about nutrition, and Colin Jarvis, Vice President of Stealth Belt, talking about physical activity. And then to wrap it up, we have Molly Atwater, our Volunteer Director of Young Adult Outreach, wrapping it up with a special mental health moment at the end. There are opportunities to write in your questions, and each speaker will speak about 30 minutes, and we'll look at the questions, and I will present them to them, and they will answer. So say whatever you want to say that I can possibly repeat on the great big web. So allow me to introduce our first speaker tonight. Isn't this exciting? Dr. Rob Fern. Wait till you listen to him. He's so cute to listen to. He is the Assistant Professor of Medicine at University of California, Irvine, and Chief Medical Officer of 11 Health. With over 15 years as a physician and a gastroenterologist, gotta love that. He knows about intestinal failure, all things about ostomy, and lots to know about bowel diseases. He comes to us with an extensive background in medicine from the University of Leeds School of Medicine and schools from London and Cambridge. He studied further in nutrition, intestinal failure, and intestinal transplant. A strong advocate for innovation and the use of technology, Dr. Fern has worked with 11 Health since 2016, developing smart products and patient-centered care models for ostomates. We are so fortunate to have him with us today. So, Dr. Fern, take it away. Enjoy your presentation, and we will hear your questions, people coming in for questions for you later. Thank you so much for being here.
Thank you, Brenda, and thank you so much to the UOAA for putting this event on and for having me here. I think the work of the UOAA is absolutely fantastic. It's critical in both patient advocacy, research, and patient support. So I'm really delighted to be here, and thank you very much indeed. I'm going to be talking today about hydration in ostomates. If we can switch the presentation into presenter mode, that's fantastic. So I'm talking from my perspective as a gastroenterologist who's seen a lot of patients in the intestinal failure field, and that's really the result of catastrophic issues with the bowel, whether it's related to inflammatory bowel disease, malignancy, or acute events like blood clots leading the whole bowel to be removed. And as a result, I've seen people with almost their entire bowel but a stoma, and some with extremely short gut, and the problems that go with that. I'm going to talk about hydration in particular because it's an issue that I think is well recognized as something that ostomates are at risk of issues with, but people don't always understand why. And there are some subtleties to it that mean it's not just about what you drink, and it's not just about kind of knowing that if you're thirsty. There's quite a lot more to it than that. And we're going to take you on a walk through the physiology of why hydration is important, and what can cause the issues with dehydration and other complications. So let's take this on to the next slide. So if you take the gastrointestinal tract and you look at it kind of without the rest of the body involved, it looks something like this. So you can see at the very top of the picture, you've got your esophagus leading into the stomach, and then the small bowel kind of wriggles on for about 3.5 meters before it joins the colon. So this is what most of us begin with. Some of us today have less of it than others. So let's take this on a slide and just turn this onto its side, and then take it to the next slide, and we can see what it would look like conceptually. So here you go. At the top part of your bowel, you've got about 70 centimeters of esophagus and stomach. You've got about 3 to 5 meters of small intestine and about 90 centimeters of colon. And the bowel is a really incredible organ. And I don't need to tell you guys that, but what I find fascinating is how highly specialized each part is. So up here on the left side of your screen, the esophagus and stomach is designed to churn your food, to add acid to it, to mince it into a small paste. The duodenum is designed to release your digestive enzymes. The mid part of your small bowel to really start to absorb those nutrients. And then down in your ileum towards the terminal end of the small bowel and into your colon, it's picking up those last few minerals and removing the fluid from the stool. So what comes out at the other end is usually a nice formed motion. So let's think about this in slightly more detail. So if we take it to the next slide, why is this relevant for hydration? Well, actually, that specialization means that the different parts of the bowel are handling fluids in different ways. So the stomach and the first part of your small bowel are actually releasing a lot of fluid. So it's a net secretor. So fluids are being pumped from the cells of your body into the center of the bowel, really to help mix up the food and hydrate. They are, and this is really important because this is vital to your digestive processes. You need the fluid there, otherwise the food isn't going to propel through the bowel. And you actually produce a lot more fluid in this part of the bowel than you're drinking. So coming through the stomach and the small bowel is something like 3 or 4 liters of fluid a day. You're probably only drinking 1 to 2 liters a day. So your body's actually pumping actively fluid into that part of the bowel. Whereas the colon and the end of your small intestine is designed to absorb fluid. It's kind of a sponge. So that's kind of taking it back. So it's done its job. It's helped mix everything up. It's transported the fluid and the food through your gut, and now your body wants it back. So that's what the small intestine, the end part of the small intestine, the colon is for. And if we take it to the next slide, we can see that the proximal part of the gut is like a leaky tap, and on again. The distal part is, and the sponge is slightly concealed by me, but the distal part of the bowel is the sponge. And what's interesting is it's not just the length of bowel that's important here, it's the role of the colon. And in particular, if we go to the next slide, it's this little thing here, which is your ileocecal valve. It's the junction between the end of your colon, as I would see it during a colonoscopy. If I've seen this, eureka, I've made it to the end, if you have one. And then that's the junction between your small intestine and your colon. So this valve does some special things. It looks like a kidney bean, but it's actually quite an impressive piece of organic material. it creates a physical barrier to slow the fluid down and allow your bowel to absorb it a little more. It provides a neurohormonal control as well. So it releases peptides and hormones, which actually slow the whole transit of your bowel down. And that allows you to absorb fluid as well. So just the presence of this little thing here makes a big difference. So you can imagine what's going to happen if you start removing parts of the bowel. If you take the colon away, even part of the colon, you're slightly reducing your absorptive ability. You go all the way through and you take off this valve as well. You're also removing that braking mechanism and the hormones that are slowing the rest of your bowel down. And the more you chop away of the small intestine, the closer you're getting to the leaky tap and the further you're getting away from the sponge. And that's important because, you know, there's only so much that you can do about compensating for that by either drinking more or changing your behaviors. So if we go to the next slide, I'll talk a little bit more about why some of this is happening. So people think that dehydration is just where's water. If there's water, you know, in the bowel, your output will be higher or your stool will be more like diarrhea. If it's out of the bowel, then you'll have constipation. But actually, no one really thinks about what's driving that. And what's driving that is actually salt. So plain old sodium chloride. So all these yellow dots represent sodium molecules. And if you take it to the next slide, we can see where water is. So water in the usual state is kind of fairly evenly distributed. We'll talk a little bit more about this in a moment, but you've got some water in your cells, water around your cells, water in your bloodstream. So what's the relationship between sodium and water? If you move on a slide. So if this was a perfect sort of physiological body and everything moved as it should do, then you would find salt and water moves equally. And you might remember this from high school chemistry or biology, but basically where there's salt, water will follow, and provided the everything is behaving like a small porous material, like a net, then everything will equalize across that. But that's not actually how the body works. So your cells actually have pumps inside them which drive the sodium to one side or the other. And how many of those pumps depends on where you are in the gut. So let's go to the next slide. So this is the foregut. This is the stomach and the small intestine, you know, the duodenum and the jejunum. So the first maybe 2 meters of your small intestine. And like I said before, this is the leaky tap area. So in this part of the body, the cells are actively pumping more salt into the gut than they are to other places. And as a result, we can move to the next slide. We can see movement of water goes from the bloodstream through the cells and into the gut. And that's what's driving that leaky tap. If you go to the next slide, and again. So in the colon and the terminal ileum, it actually works the other way. So if we move on, we can see that these sodium molecules are being actively pumped from the gut through the cells into the bloodstream. And as a result, on the next slide, we can see that that's what's leading to the sponge mechanism of the colon. So again, we now have a reason why people with shorter guts have higher output, and we have something that we need to treat that's more than just fluid. So when your physician turns around and says, you know what, you've got to drink not just water, but lots of electrolytes, this is the reason why. It's that if you don't have the ability to reabsorb your salt, then not only are you pumping salt into the bowel, but water's following it. So you need to replace that water and you need to take electrolytes with it. Now it gets more complicated the shorter your gut is, because even drinking the fluids might not be enough, but we'll talk about that in a moment. Let's go to the next slide. So why is dehydration important? It's something we kind of all intuitively know about or think we know about, but actually there's quite a lot to it. So our bodies are, even before we start doing anything with it, we're about 60% water. That water is inside our cells, it's around our cells, and it's in our bloodstream. So all in all, in the average 70 kilogram man or person, I'm not sure how many people are average anymore, but the average 70 kilogram person is about 60%, so about 41 liters water. If you are pretty much within the range of being completely hydrated or about, between 75% and 100%, you'll have no symptoms at all. You'll feel well. You'll have no thirst. You'll have no issue. The clinical impacts of hydration are actually really interesting, because you can be dehydrated to quite an extent before you even see any symptoms at all. So if you get to about 25% dehydrated, so your fluid level drops from, say, 40 odd liters to about 30 odd liters, then what you'll find is you'll either feel the same, you might have some slight thirst. If you do some clinical tests, the heart rate, particularly in young people, your heart rate might be normal, your blood pressure might be normal. You've lost a quarter of your body fluid and you have no real signs of it at all. If I did a postural blood pressure, so ask you to lie down, stand up for 2 minutes, check your blood pressure in both positions, then I might see a drop. I might see your heart rate increase when you stand. I might see your blood pressure drop a little bit. So these might be the only signs. But they're not to be ignored, because you drop a little bit more than that, you get to 50%. That's when you start seeing high heart rates, bigger drops in blood pressure, maybe a sustained drop in your blood pressure even when you're lying down. You get to 75% dehydration, so only 25% of your normal fluid left. That's when you're in a critical clinical situation. So organs will start to fail. You may well lose consciousness. You will need intravenous access and fluids, and you may well need intensive care, because this is shock. So really, the goal that we have as clinicians is to try and keep you, between the 100% and 75% mark. It's more than just, and let's talk a little bit about the symptoms you might experience. So we talked about the things like the blood pressure and the heart rate, but as an individual kind of monitoring their own symptoms, what are you going to feel? Well, the first thing is thirst. Thirst is a very interesting kind of mechanism. It's controlled by the brain. You have some very sensitive bioreceptors which look for small changes in the concentration of salts in your blood, and they tell your brain to say you're thirsty. So thirst is a very, very sensitive marker. And it's very effective. Most people's blood sodium stays in very, very tight ranges for long periods of time. Even when they're quite dehydrated. So thirst is the first thing. I talked about that drop in blood pressure when you stand up. So that's going to make people feel dizzy on standing, potentially. That kind of slight wooziness. You might get some palpitations if it's a little bit more severe. You might feel nauseous. Nausea is a sign, and some of the softer symptoms like brain fog or nausea or just feeling fatigue are sometimes harder to pin down to hydration themselves, but can often be, a lot of people report those sort of symptoms. But the harder symptoms are the postural dizziness, the thirst, and particularly the urine color. So a dark yellow or brown urine is clearly a matter of concern. Let's take it to the next slide. So let's talk about, more than just the clinical symptoms of dehydration. If that was it, then that would be bad enough. Nobody wants to feel dehydration. No one wants to feel perpetually thirsty. But in that previous slide, I showed you that only really becomes dangerous when you're more than 75% dehydrated. But that's ignoring something really, really critical here, which is your kidneys. Now, your kidneys are something, or our kidneys are something we all take for granted. Most of us have 2 of them. You can be perfectly fine with 1 of them. But the great thing about the kidneys is that you have a lot of reserve. So this is a conceptual chart. Don't worry about the numbers themselves. But what this says is, when we're born or we're young or we haven't had anything to damage the kidneys, our glomerular filtration rate, the rate at which fluid passes through the kidneys, is pretty high. Let's call it 120. It could go all the way down to 60 before we consider it abnormal. So you could lose half the function of your kidneys. In fact, we could take a kidney away. A lot of people donate a kidney for transplant. And you still have a normal kidney function. But then look what happens. Then as soon as you cross that threshold, you go into kidney disease, and then you're not far from kidney failure. So if I take it to the next slide, I'll just show you the significance of that. So somebody with a normal kidney has an injury, call it an injury. This is, let's say you get high output stoma 2 or 3 days in a row, and your deficits, the difference between what you can drink and what you lose, is more than 3, 4, 5 liters. If we tracked your kidney function, we would see it go from from a very high number to a what's still considered a normal number, but much, much lower than it was. And then if I fill you up with fluid and electrolytes and, you know, spend a couple of days in hospital, it might recover, but it's unlikely to recover to where it was because that's damage done. That's an injury to the kidney. It's only replaceable to a certain extent. Now take somebody who's already got a little bit of damage. So, you know, particularly chemotherapy drugs or certain biologics, certain IBD drugs can impair your baseline renal function. It still might look normal, but it's not quite as high as this one over here on the left. Now a dehydration event happens and your blood tests show, actually, this is kidney failure. This is acute kidney failure, acute kidney injury. Let's get you in hospital. Let's give you the fluids and it improves. And again, it looks normal. We're all happy. But again, that's lower than you started. So keep doing that. Keep going into hospital every 2 or 3 weeks with episodes of dehydration or allowing yourself to get kind of more than 20% dehydrated. Now look what happens. Now you're in the, I can't recover from this zone. So each additional hit, each additional piece of damage damages those nephrons, those little tubules in your kidney to the point they can't quite come back. And this is one of the big risks of recurrent dehydration, particularly in ostomates. The more episodes of seemingly mild dehydration that occur, the more damage accumulates. And over time, that damage may become irreversible, may become chronic kidney disease, and in the worst state may become end-stage kidney disease, need dialysis or a transplant. That's what we're trying to avoid. Let's go to the next one. So I put this in because sometimes people need to see sort of other motivation for doing something about these kind of things. The costs of even just acute kidney injury, not even counting chronic renal failure, are huge. There's something like $9 billion a year in the US system. They add to the length of stay in hospital. People die from kidney disease. And it's affecting over 1 million people during their hospital stay. So that's 3.5% of all hospital admissions. Let's go to the next slide. So we've talked about the causes of dehydration. So just kind of walking all the way back, we talked about the anatomy of the bowel. We talked about why the front part of the bowel is a leakier organ, so pumping salt out and fluid out into the center of the gut, and why the last part of the bowel is more of a sponge. Why, if you've had the colon in particular, the ileocecal valve, or any length of small bowel resected, you're more likely to have high output, and how that's driven by salt loss. We've also talked about the clinical symptoms and the impact on the kidneys. Let's talk about what we can do about it. So a lot of people talk about oral rehydration solution. Sometimes people mix up the idea between just drinking electrolytes or things like Gatorade and what is generally oral rehydration solution. So let's start with the basics. If you drink water alone, you're not replacing the salt that you've lost. So the more water you drink, potentially you could actually be driving the problem, making it worse, because you need that salt to pump some of that fluid back into your bowel. You also need some sugar, and that's because there are receptors inside the bowel which are sensitive to both salt and sugar to pump through, and that's what we're seeing here. So if I give you water with the right concentration of sodium and glucose, not just any sugar, but glucose, then it will activate the cells to pump the fluid back into your bowel. And that's what you're seeing in these three pictures. So on the left, we've got some water, we've got sodium and glucose. That sodium and glucose is activating the pump, and the water's being pumped in. And then once the water's in, the sodium and glucose follow. That's the principle of oral rehydration solution, but you have to get the concentrations right. So I'll take it to the next slide. Don't worry too much about what this kind of the numbers on this slide, but what I do want to show is when we give people with short guts, with less than 2 meters of their small intestine remaining, we give them electrolyte solutions. We look a lot at the concentration of sodium in that fluid. So the column on the left-hand side has 60 millimoles of sodium. That's the average content, maybe a little more than your average kind of Gatorade or electrolyte solution. And what the graph is showing you is when you give people with a short gut something like Gatorade, it will actually drive fluid out. They will lose fluid as a result of it. So they go negative. The more sodium you put into that fluid, the more they retain it in their body. And so it seems counterintuitive, but sometimes the shorter the gut, the more salt you have to add to the fluid. And it makes it taste disgusting. But if you look at it this way, this can be the difference between life-threatening kidney failure or not, or lifetime weekly IV fluids, or being able to live free at home, as a result of this and some other medications. So we'll take it to the next slide. So just to walk you through, I guess, what I would do as a gastroenterologist assessing a patient who seems to be having recurrent episodes of dehydration, or is just worried about their dehydration risk as an ostomate. I would say, how long is the bowel, the residual bowel that's been left in the body? And that has to be really the bowel, the usable bowel, so the bowel in circuit, the distance between the end of the stomach and the start of your stoma. That's going to tell me a lot about your ability to stay hydrated by oral fluids alone. The stoma type is going to be important to that. So colostomy, an end ileostomy patient should be able to manage with oral intake alone. There's some reasons why they might not be able to. Loop ileostomies tend to be a bit higher in the bowel. Then you have your jejunostomies or duodenostomies. They're much higher output. So let's talk about those separately. But we record our residual bowel length. We make sure, particularly if someone's output has increased recently, do they have an infection? Is there any active disease? If you had IBD as the cause of your stoma and suddenly your output has increased, I want to know that you don't have active Crohn's disease or a recurrence. Infections can certainly drive high output. It's really important, and if you just click to the next slide, the next three are really critical to the management. So knowing exactly what has come out is absolutely critical, because that helps you work out what is possible to replace orally or what might need to be replaced by other means. We try to use objective markers of hydration, so something that isn't too kind of dependent on I feel this or I think that. So we'll look at the kidney function, the sodium in the urine, which is a really useful marker, and the urine output. And they help us a lot to determine kind of clinically how well or unwell is this patient now. And finally, we'll treat accordingly, preferably using oral intake, so fluids with electrolytes at the right concentration, medications to slow the bowel rate down, diet changes, which hopefully we'll be talking about shortly, and managing the underlying condition to try and normalize the output and reduce the risk. And really, this comes down to balance. Can you get as much fluid and electrolytes in as you're losing? Because if you can, you don't need any IV fluids or anything else. And so much of it will come down to that. Let's take it to the next slide. I think that's the end of our session on hydration. So, hi, Judy.
Okay, well, that is really great, Dr. Rob. And we do have some time for questions. We have had a lot of people coming in and out of your presentation, and they're asking, let me just get a couple. One is Skirt Girl Hiker. She's a South African ostomate. And she was asking, why is it when I drink water, it feels like my body is not absorbing? I keep drinking and drinking to a point my stomach is full, but still thirsty. Good question. Thank you.
So that's a really good question. And I obviously don't know the full details of your case, but what I'll talk in general about why thirst is a very common symptom despite drinking. And the reason is, thirst is triggered by the loss of fluid and electrolytes. So your salt level drops, your brain tells you that you're thirsty. If your output, if you don't have the ability to absorb lower down in your gut and you just keep drinking water, then actually you're adding to the problem. You could be losing that water that you've taken in plus interest. It's washing out all the extra salt and fluid in your bowel. So we often see people who drink, maybe 1, 2, or 3 liters a day, and 4, 5, or 6 is coming out. And that's because of the loss of that absorption. So the first thing is to know how much bowel is remaining. And that's something to discuss with your medical teams. The second is to keep track objectively of the amount coming in plus the amount coming out, because it may be that that there's a mismatch there, and if more is coming out than is going in, then you definitely need different management. The approach by using the right type of electrolyte solution, and this is something you should get medical advice for, either from a WOCN or from a physician that's comfortable in the area. The right kind of fluids can tackle both the thirst and the underlying hydration and high output problem.
Very good. Thank you. Here's a question. I'm not even sure how to say a couple of these words, so I don't know if this is another doctor talking. Evanis Pineda, please explain osmolality considerations and oxalate foods. Now, I don't know if the foods part is your part or Judy's part, but take it away, Dr. Fern, if you understand this question.
So I'll try and tackle it, and Judy may have some input on this as well, because I don't claim to be an expert on all of the aspects of oral intake. So osmolality is important because osmolality is effectively what is the pull power of a fluid or a substance that you eat or drink. So when that sits in your bowel, a high osmolality compound is going to draw fluid in or prevent you from absorbing that fluid. So we tend to advise ostomates to stick with lower osmolality foods and fluids. A good example, the classic example is something like lactulose. So lactulose, which is a common laxative, is actually just a very high osmolality sugar. It isn't absorbed by the body, but it's very, very active at drawing fluid in from the bowel, and that's why it gives us diarrhea. And a number of kind of more commonly found foods and sugars can also do the same thing. So things like sucrose, the kind of sugar substitutes that are in different foods will all contribute to osmolality as well. I think Judy's going to talk a little bit about these topics, so I'm going to leave it there for now and let Judy pick that up.
Okay, well, here's another question. Anne-Marie is wondering, is the information you shared the same for urostomies?
Can you just repeat that question for me?
Is the information you shared the same for urostomies?
So that's a really good question. It's slightly different for urostomy. So in urostomy, you're sort of cutting out the middleman, if you like. So the idea of the length of your bowel and what you're taking in, driving your output, doesn't count for urostomy. But urostomy is now your window to kind of seeing what's going on. So the color or content of the fluid will give you a lot of information on your hydration state. The assumption would be that you still have an intact gut. So as long as you can still absorb fluid, then you shouldn't require, for example, IV fluids to manage your hydration with a urostomy. And you might not even require electrolytes. So normal diet and normal fluid intake may well be enough for a urostomy. Now, the caveat to that is that a lot of patients who've had a urostomy have existing kidney damage because of the condition that led to the urostomy in the first place. So there may be other reasons why fluid or kidney function is a reason, but it shouldn't be necessarily related to the gut in the way that I described it in this talk.
Very good. Also, GOF, with a normal gut, what are the hydration requirements?
So that's it's different in different people, but it's approximately 25 milliliters per kilogram per day, and the idea would be just plenty of fluids. It's about a millimole of sodium per kilogram per day as well, and potassium. And a normal diet with water should be more than enough for somebody with an intact colon and an intact bowel.
Very good. Ginny from Indianapolis writes, I've never been concerned about my salt intake, though I do not overdo it. I have high blood pressure, which is controlled by medication. I have never had kidney stones either. Should I be careful about my salt intake, age 69?
So if you've not had previous issues with either your kidneys, with kidney stones, kidney function, or symptomatic dehydration, then there's no hydration reason to kind of increase or decrease your salt levels. Now, the impact of dietary salt on blood pressure is important. And so it's worth sticking to the kind of guideline dietary amounts for sodium and potassium, again, which is about 1 millimole per kilogram per day. You can find the percentage on any given thing on in terms of your recommended daily amounts on most boxes of most foods. So follow normal nutritional guidance. Depending on the way that your blood pressure is managed, the oral salt intake may be very important. So speak to your physician about the impact of salt on your blood pressure.
Very good. Michael Brown asked, output from my ileostomy is sometimes thick and sometimes liquid. I have no colon. Why isn't it always liquid?
It's a really good question. And I think the reason is what drives the output liquid content is the result of about 100 different processes going on. Some of that's related to your diet. Some of it's related to the salt and fluid intake. Some of it is related to your gut motility. So intrinsically, how those nerves are kind of firing, the hormones that control some of those nerves, and finally the bacteria inside your bowel. And all those things kind of act in different ways to give us different output at different times. So it's never as simple as saying, I have this much bowel, I should have this type of output. But there are often some patterns. So certain types of food, particularly with different levels of fiber intake or fluid, may well change your output. But that's sometimes that kind of variability is just normal, and it can be normal for someone with an intact bowel as well. You know, it can be in certain forms of irritable bowel syndrome, we see huge swings from diarrhea to constipation with no physical problem to the bowel at all.
Very good. And Matt wonders, I was told by my surgeon for my end ileostomy to use Gatorade G2 or 0, which are low or no sugar. But you are saying we do need sugar to maintain hydration. Which is the safer way to go?
It's a little more complicated than saying you always need sugar. But if you look at most commercially available rehydration solutions, and those that are used particularly for patients with a short gut, then they usually contain glucose as well as the electrolytes. The fluid and electrolytes is better than just the fluid alone. And particularly for people who either have diabetes or other sensitivities to sugar, that might be exactly the right thing to do. So it is case by case. I would discuss it again with your physician or dietitian. I'm not a big fan of recommending the commercially available sports drinks as ileostomy hydration because the exact concentrations don't always meet the need. So that's why I would generally recommend the things like either drip drop or the commercially things that are designed specifically for ostomate.
Very good. Well, you know, we have to wrap up your time, but Dr. Fern, I particularly liked your graphics. I've never seen any quite like that before, and they were fun. And I really appreciate you answering everybody's questions that we could fit in this short time. But now it's time to move on to our next speaker. Thank you so much for being here. And I'm happy now to present our next speaker, Judy Madura. After working in healthcare in 10 years, first as a registered dietitian, then she became a registered nurse, and then a WOCN, wound ostomy continent nurse. We love that about her. She has tons of experience in acute, home care, long-term, outpatient, industry, legal, risk management, and performance improvement. Man, she must be tired, is what I'm thinking. Judy is currently the director of wound ostomy and hyperbaric services at Honor Health in Scottsdale, Arizona. She has been an active member of the WOCN Society in leadership roles and presents regularly at ostomy and WOCN meetings. The favorite part of her career, she says, is a culture of learning, collaboration, and encouragement. Well, I think she's got that mastered. Well, Judy, we are looking forward to being encouraged by you today. Thanks for being here, Judy. Take it away.
Well, thank you. That was a nice introduction. And I'd like to thank everybody for being on and listening and learning with me. I do want to share that we'll pull up the slideshow here and we'll go to the second slide. That what I want to share with you is information that I've learned over the years in my career, but a lot of it came from Ostomates and a lot of it came from my colleagues. So I'm not going to replace any of your any advice from any of your physicians or your healthcare providers, but I hope it complements what you're learning from them. So let's get started. And in the next slide, we will talk about some of the common goals that you hear about whenever you have ostomy surgery or you read any materials on ostomy. The common goals include promoting adequate digestion and absorption, which we'll talk about today. Also preventing any stoma obstruction. We also want to minimize odor and gas. And most importantly, we want to get back to your normal. It's not about what's normal as a general term, it's what's normal for you. So in talking about that, let's get started and we'll get into more details with our next slide. One size does not fit all. So the information given is a little bit more general, but each of you are different. So what you're learning here today may or may not apply to you and may apply to you in different ways. So want you to take this information and then learn from it and learn to see how your body responds to the information and the intake. So if we go to the next slide, we are going to just give you an overview of nutrition and learning how to take care of your body with an ostomy. So first things first, just give yourself time. Whenever you have any type of procedure done, whether it's a new ostomy or any other type of situation in your life that may put stress on your body, and that includes stress on your mind because that will affect your body, give yourself time to recover and get back to your normal. And as Dr. Fern stated, we want to keep track of things. So you might want to start some form of diary, some type of log or something just to keep track of what you're experiencing. It might be a new food that you're trying. It might be how much fluid you're taking in as well as your output. And this is going to help you to learn about your body because it's really learning about you, not necessarily learning what is good for everybody. It's learning about how you respond. You want to learn about nutrition because there are a couple terms that came up already, which we'll discuss, like osmolality, and that plays a role in nutrition and the food that you're going to take in. One key point you want to be sure to follow is make changes slowly. If you're going to do anything new, give your body time to adjust. So be slow in the changes. And then most importantly, be kind to yourself. And this is both emotionally and physically. Just understand that any type of stress that you're under, whether it's physical stress or emotional stress, you need to be nice to yourself, be kind to yourself, and help yourself to move forward. All right, so let's go a little bit further. And we're now going to start talking about digestion and absorption. And I'm hoping that what I'm going to present is going to complement what Dr. Fern already presented. So when I think about nutrition and whenever I talk about nutrition, there's a lot of factors. There are we can look at fat, carbohydrates, fibers, the different types of fiber, sugar, protein, fluid, vitamins, and minerals. So we could be talking for a long time. So today we're going to focus a little bit more on the carbohydrates, specifically the fiber, and we'll touch on sugar as well, and the vitamins and minerals. And if we go to the next slide, the first thing we want to discuss, and again, a little bit more of a compliment to Dr. Fern's presentation, is know the site of your stoma. There's oftentimes as a nurse that patients will come in and they're not sure what body part their stoma is from. So it's good for you to know that, and then you could help to learn more about yourself. And so there's just the pictorials of, the different sites of where you might have your stoma. And then also with a urostomy, if you have an ileal conduit, that is good to know. All right, so let's go a little bit more of a review on digestion and absorption. And again, as we previously learned, digestion and absorption, it starts at your mouth and it goes through your whole digestive system all the way down to your anus. And there's different parts of the digestive system that absorb different nutrients. And you could see, as Dr. Fern had mentioned, that a lot of your vitamins and minerals are absorbed in your small bowel. And that is where we're going to concentrate a little bit more in our discussion today, but also important anywhere in the body to know yourself and to know a little bit more about the sites of absorption. All right, so let's get into it a little bit further with the next slide. And we're going to talk about absorption. So couple points to remember: certain things decrease absorption and certain either foods or stresses increase absorption. And the one thing you want to keep in mind is that anytime you have a new ostomy, it might take a year for you to return to your normal. And again, keep in mind, it's your normal. It could be less than that, it could be more than that. But typically when you have surgery, it's a stress on your body. So it's going to be a time where you might have decreased absorption. Also, if you have any type of inflammatory process going on, especially in your gut, you may see that absorption is decreased. And emotional stress definitely plays a role on our physical body. So that is also a risk factor for decreasing absorption. And chronic diarrhea, whether it's from that stress you're under, whether it's from something else, again, can decrease absorption, as well as certain medications such as steroids. So how do we increase absorption? We'll talk about some foods that are going to be right for you. And sometimes it's time, it's periods of rest. And that rest could be, we could look at it both for your gut as well as your emotional state. And just time and care, taking care of yourself and taking time and allowing yourself that time. So we'll go to the next slide. And the first thing you're going to hear after you have surgery, and maybe even any other types of surgery that affect your gut, is that you should be following a low residue diet, low residue, low fiber. So I wanted to share some foods that are low in residue and high in residue, and then compare those with some of our high fiber and low fiber diet foods. And the reason we look at residue is because foods that are high in residue, they leave undigested particles in your gut, and it can increase stool volume. And it's not the same as the low residue foods. Those are the ones that are going to give your bowels time to heal and just to rest. Typically, low residue is a short-term eating plan. And, I don't want to completely generalize, because I want you to think of yourself as individuals. But when we talk about short-term, we talk about approximately 4 to 6 weeks. So you'll see that some of those initial foods that are just going to give some time for your gut to rest are going to be the lower fiber foods that are going to be like your white bread or your white rice, your very well cooked vegetables, not any of your raw vegetables, fresh fruits without the skin, including fruits like bananas and melons, and then other products like your eggs, fish, poultry, and dairy. And then some of those that are going to be the higher residue that may just hang around in your bowel are going to be those any types of seeds or strings in those vegetables, any of the juices like prune that have a lot of that pulp in there, your bran, your corn, nuts and seeds. And you kind of think of those as undigested foods. So they're not always completely digested. And sometimes you might see those in your output. Now, let's now compare that to our next slide, which will show the types of fiber and fiber foods. A lot of times we hear people say you should eat more fiber or less fiber, but you really need to know the differences in the fiber, because soluble fibers and insoluble fibers could play a very different role in your absorption, your output, the consistency of your output, how fast your output is. So you want to look at these separately and really consider which one is right for you at which time. So our soluble fibers are the fibers in foods that slow your GI transit time. They delay glucose absorption, they lower cholesterol. So a lot of benefits there. And those are similar. You'll see a little bit of overlap with those low residue foods. And those are going to be your fruits without the skin. They're going to be really well-cooked vegetables. And then your oatmeal, your oat bran, your barley, and then cooked lentils and peas and legumes and beans. And I kind of think about your soluble fibers when you could compare it to like gelatin. These are going to be your fibers that are going to gel up, and they're going to absorb fluid, so they're going to hang around a little bit and go a little bit more slowly through your gut. Now, your insoluble fibers, they might hang around, but not in such a good way. They might be strings or like the seeds or fibers that could hang around, but they also could speed your GI transit. They could they will also delay glucose absorption, but they will promote bowel movements. So one thing to note is that all of these fibers are good, but there's just times where you might need to focus more on taking in soluble fibers, and other times you might need to focus more on the insoluble fibers. So it's really good to know the difference. And then also just one other point to make when we talk about fiber is that there are a lot of foods that have both soluble and insoluble fibers. So one of the simplest ones to think about is when you have fruit with the skin on it, the inside might be the part that's the soluble, the skin might be the part that's the insoluble. Again, they're all good in some ways and in certain quantities. But let's talk a little bit more. We'll go to our next slide. And we're going to talk about, I'm going to focus on the osmolality, which was the question, one of the earlier questions, because these different foods and in different forms can also increase the osmotic effect on your body. But also there's other foods that might be introduced to you at certain points, especially if you're hospitalized, that you might want to be aware of. So when we think of osmolality, we think of an influx of fluid into your bowel. So you could see there in the picture that the high osmotic food or drink is really pulling all that fluid into your gut, which can lead to more output, high output, more liquid output. And some of these foods and drinks are those really concentrated foods or beverages. And some of them are the ones that are going to often be recommended after surgery. And very well-intentioned people will tell you something like, you need a nutritional supplement, or you need to drink some of this Boost or this Ensure. And by no means are those bad products, but sometimes it might be too much for you at certain times. So if you're finding that those types of supplements or other, high osmotic foods and beverages are causing you to have higher output, which is therefore decreasing your absorption, you might want to try them in a diluted form, or you might want to try them in smaller quantities. So going back again to the nutritional supplements, I often tell people, if you're told you should have 3 cans a day, maybe you should half that amount, like drink 4 ounces at a time instead of 8 ounces. Or pour it over ice so you dilute it a little bit. And then that way you're still getting the nutritional benefits, but you're not putting so much stress on your gut that is causing the high output. And then some of the other products or foods that might cause this osmotic effect are going to be really super sugary foods and treats, and some of the things that we all really love, but just too much too soon, or just too much in general might not work for you, or you might need to avoid them altogether. So, I'm just going to name some favorite things, such as, your blizzards or your Frosties and things like that. They're great, but there's where that sugar could come in. It could be too much sugar for you. And then also some of the things you might not think about, like artificial sweeteners, sometimes those, could cause issue. One key thing that comes to mind, and it was a very nice gift, but not necessarily long-term good effects. Somebody who was having some issues with, managing their output was given sugar-free candy, great box of chocolates, and it was so delicious, but they ate way too many. And that artificial sweetener in there, they just caused high output loose stool. And that's because of this effect that we see here. And in addition to that, sometimes you got to be careful about your very lactose-rich foods and drinks. That's whether you're lactose intolerant or not. Lactose may cause you to have this osmotic effect. So again, the high osmotic foods can lead to high output, frequent output, and then possibly dehydration as well. All right, so let's go to the next slide, and going to look at a couple other foods and beverages that may trigger higher or increased output. And those are your alcohol, your different carbonated or caffeinated beverages, the legumes such as the beans and lentils, vegetables high in fiber, nuts and seeds, and your whole wheat. Now, again, it's not that all these are bad, but you really need to know what amount is right for you. And then also know if you're in a period of stress, whether you just had surgery, or you have some other type of stress, or a new medication that's stressing you, or something else going on, you might have to cut back a little bit on these products and give your body some time to readjust and then represent them slowly. And this is where that food intake, that food diary, that food log, that all comes in handy. If you jot these things down, you can look back and say, oh, no wonder I'm having such high output. This is what I've been eating or drinking. And then you could know to cut back on it. And then again, take it slowly with reintroducing it back to you. All right, so let's move on. And what can we do when we have those situations where we have a lot of high output and we really want to thicken the output, thicken the stool? These are foods that may help. And you may have to, again, take them in small portions. They're going to include creamy peanut butter. Don't get the crunchy kind, because those nuts in there will not be very good to your bowels. Bananas, cheese, boiled milk, marshmallows, pasta, and then white, not whole grain bread or toast, rice, tapioca, and then applesauce and potatoes. The applesauce, you should go with the unsweetened. Sometimes those that we buy over the counter are really, really sugary. And I don't know how many people remember the term the brat diet, but this is kind of where this started. So the brat diet was given when people had, especially kids, had diarrhea, and it was bananas, rice, and then it was toast, or bananas, rice, applesauce, and then I always say tea and toast, but the tea would be decaf, and somewhat diluted. But then also the toast would be the white toast or the plain toast, nothing with any whole grain or nuts and seeds. And this gives the opportunity to thicken your stool, but also to rest your bowels a bit. Okay, we'll move on to the next. And we are going to look at how we can prevent stoma obstruction. And then the next slide will show some of the foods that may obstruct your stoma. And a lot of these are very well known. I think most information that you receive on ostomies and how to manage after surgery will share these. But you might learn as you see what's coming into your pouch, coming out of your body, or if maybe not coming out, and just with a little bit of probing, you might see that those foods stuck there. So really want to be careful with some of these foods if you're having issues with obstruction. And you may or may not have this issue. I've heard many people say I've never had a problem with any of this. And I think some of it is a combination of really chewing your foods really well. That really helps you to start that digestive process. And remember that the digestion starts with your mouth. So really chewing your food really well. And then also smaller quantities. And then also making sure that you're not having a lot of these different types of foods together. So introducing one in small quantities at a time is a good way to go. And then we move on to our next slide. And again, I just want to reiterate, chewing slowly, thoroughly, eat slowly, chew all your food, eat small meals, drink with your meals, that helps as well. And then add new food slowly, and then keep that diary. This is going to help you to know what you tolerated and what you didn't. And I think that the more you learn about yourself, the more you're going to be able to help yourself and get through any type of challenge that you might have. Okay, now just going through some foods that we can look at to help you to minimize odor and gas. And the next slide will start with those foods that may cause odors and may reduce odors. And it's really sad to see the ones that may cause odor. That list is double the size of the other one. That's unfortunate. But it doesn't mean that you can't have these foods, especially with all the new appliances we have out there with filters and so forth. It just means that you might want to look at not eating multiple of these foods on that list together, and keeping the portion smaller, and timing when you're going to have the foods. So you might want to avoid those foods if you're getting ready to head out to a public place and you might have a concern about the odor. It's really going to be up to you, and that's another note that you could put in your diary to say which ones really I shouldn't eat this, or I should really minimize this. And then you may want to look at the list on the right side, which could reduce odor and increase those foods. Now, the next slide, we'll see foods that may cause gas. And again, we're lucky that we have other ways through appliances and different filters and so forth that may help with this, or burping your pouch. But these are, again, foods that if they cause gas and they give you an issue, you may want to drink or eat in small portions. You may want to minimize the quantity that you eat, and or you may need to avoid altogether. And again, knowing what you tolerate and what you don't, that's the key point here. And then just a couple other points is, again, chew slowly with your mouth closed. And it might help to avoid straws. Sometimes when you're drinking with a straw, you're taking in a lot of air. And that could give you that feeling of being like bloated, or, feeling gassy. But that could also happen not just with straws, but eating and drinking too fast. So we had a question earlier that was in regards to you're drinking a lot of water, but you're feeling really full. It could be if you're drinking with a straw, you're drinking and you're gulping and you're going too fast. Sometimes your stomach feels full, even though it's not full, but you're taking in a lot of air with that. So maybe able to reduce that with the avoiding straws or just drinking more slowly when you drink out of a cup, and then just taking time when you're eating and drinking. All right, let's move on to a summary. So getting back to your normal, and again, this is your normal. Get to know what you tolerate, get to know what you like and what you don't like. The last thing you want to hear is, eat or drink this and you don't even like the taste. So get to know what you tolerate, what you like. Be really patient with your body. Give it time. Again, we're often told that 4 to 6 weeks after, a surgery or any type of a stress on your body is that time frame. It may be shorter for you, it may be longer for you. And then that reabsorption after your surgery, it could be a year before you're really back to your body adjusting. And again, to your normal. And then be kind to yourself. Don't beat yourself up if you're reading a list and it says you should be doing this, this, and this, and you're not feeling like you're hitting those timelines or you can't tolerate that food. Don't be hard on yourself. Be kind to yourself, because again, everybody's a little bit different. So in the next slide, I want to share with you a really great resource. This is the new Eating with an Ostomy UOAA booklet. Easy to find online. You can either order it or you could download it and then print it out, but a very, very good resource. So now I want to hear your questions. And again, thank you for giving me the opportunity to be with you today.
Judy,
any questions?
Thank you so much, Judy, for that great presentation. That was fantastic. I was just writing down, I'm not supposed to go to Dairy Queen or get a blizzard, darn it. And then I took an extra picture of that. My husband is not an ostomate, but I thought he should know about odors. And so I'm going to just copy that slide very quickly.
Go. And you can share that blizzard with your husband too.
Well, that won't happen. All right. So I want to get to your questions because there's a lot of them. Thank you for that great presentation.
Okay.
Throttlemeyer 949. What benefit, if any, does fiber provide for someone without a colon where fiber is digested? What do you think?
Well,
what benefit, if any?
All those foods, they not only have fiber in them, they have a lot of nutrients. So you're going to get your vitamins, your minerals, especially a lot of vitamins, and a lot of your fruits and vegetables that, we talk about them based on fiber, but they're really great vitamins and minerals. And, one of the things I always think about is a lot of your fruits and vegetables have your antioxidants, which are supposed to be very beneficial for you. And especially there's links with decreasing any further risk for cancer or cancer with eating more of those foods. And it also just helps your whole system. They say, how we look, our skin, whether the moisture of the skin or just our whole affect is based on what we eat. So again, those high fiber, soluble, insoluble fibers all have those nutrients in them, in those foods.
Very good. Let's see, our South African ostomate, Skirt Girl Hiker, she says, don't skins and seeds cause blockages? I'm a new ostomate and I've had a bad blockage from corn. I was told never to have it.
So that's typically what you're told, and I could tell you from just talking with ostomates in different settings, many of them can eat corn. So again, you got to learn what's best for you. The main thing is give yourself time to get your body back to its normal, and make sure you chew really, really well, and make sure you eat other foods, but not a lot of other of those foods that may cause blockage together. So for now, if you've had a bad blockage, I would avoid it. And if you're going to try to introduce it at another point in your future, definitely think about very small portions and chewing really, really well.
Yeah, and don't have a political discussion or watch a scary movie while introducing new foods because you forget. All right. How about Dorothy Kent? Does it matter if you sip versus gulp liquids?
I think so, yes. And I could say from experience as well as from, just talking with others. When you're gulping, that's when you're taking in a lot of air. That's where you're going to feel bloated. That's where you're going to maybe not eat so much, which if you need to eat, that could be a bad thing. I know, a lot of people who are trying to lose weight always say, oh, I'm going to drink a lot of fluids before I eat. And then that way I won't have, decrease my appetite. That's not always good. So I would definitely say sipping is going to be the kinder thing to do to your body.
Way to go. And Barbara Jordan asked a question I think about a lot of times too. When you have a high output, is it usually the most recent thing you ate or drank, or could it happen from a previous meal?
That's a really good question. It's typically more recent, and I might defer to Dr. Fern for this question if he's still on, because it can be a combination of things. It could be previous plus current, and it also could be what you ate as well as any medications that you might have. I see Dr. Fern just joined us, so I want to listen to him.
Yeah, I think you got it exactly right, Judy. It depends on all those factors I was talking about before that can impact your stoma your output consistency and motility. So that does include what you ate, and the best test for kind of how long something takes to go through is that piece of corn or a seed. If done safely and obviously make sure you're not taking any risks there, but really that's the best evidence, and usually it takes for someone with an intact bowel 1 or 2 days for food to pass through. So what you're seeing, and for a stoma it might be reduced by maybe up to half or less. So what you're seeing is your most recent meal, yes, because even when you eat, your stomach stretches, and that sends a signal to your bowel, and your bowel starts contracting. But it's also what you ate. So what was in there, 3, 4, 5 hours ago, because that's still passing through. And the variables like how long your bowel is and what the bacteria of your bowel are doing will have an impact as well.
It might be even helpful to keep a little journal if that's happening every once in a while, and they can kind of track it that way.
Yeah.
Okay, thank you for that. Deborah Benson says, I've had my ostomy for 10 years and have infrequent motility. The output will come out but stop at the pouch. What can I do to increase my motility?
Sure. And I think you really need to look at what you've been eating. And that's, again, where that diarrhea or that log will come in, but also what you're drinking. So sometimes it's related to not having enough fluid with your food, and sometimes it's the food itself. And you also want to look at if you introduced anything new when you're having those infrequent motility issues. And so if you look at everything together, and then you could take a look at, all right, if I want to increase motility, you might want to look at those higher fiber foods. But again, make sure you're drinking plenty of fluid with those foods, but don't go all at once. Don't use that no pain, no gain, old exercise theme we used to have. You want to really introduce your foods and your beverages more slowly.
Great. Natalie was asking, let's see, oops, where was that question? I missed it. I might have to come back to that. Natalie, how does this relate to having a urostomy? I have both colostomy and urostomy.
So most of what I talked about relates to the colostomy. And the urostomy is going to there's not going to be as big of effect from the food on the urostomy. It might be more the beverages that we talked about, the drinks that we talked about. So I would focus on the output of both, and as well as though like keeping a track of what the output is for both, but also what you're taking in. And you might see some changes in the urine output, but probably more from the colostomy than the urostomy.
Great. Colonel Justin Bloom, I've had my ileostomy for 38 years, and I truly benefited from this presentation. Great reinforcement of information I have learned over the years. So we're right on track, which is great.
Thank you.
Deborah also said, Deborah Benson, I was told to take Metamucil every morning. If I take it, when should I take it, before or after medication?
So I would go back to whoever prescribed the Metamucil every morning, as well as who's prescribing your medication. That I would recommend you talk with that provider.
Mm-hmm. And I'm sorry if I'm butchering your name, Evanice Pineda. Thank you, Judy. Can you please talk about oxalate food considerations in relation to kidney health and life with an ileostomy?
So that's a really interesting question. And I think that, oxalate foods might be a whole other presentation, and just have had a lot of personal experience with that, with family members and my husband and so forth. But high oxalate foods can cause kidney stones, which can lead to your kidney health failing or other issues. So what you want to look at is, and it's pretty easy to find a list of high oxalate foods if you look online and look at reducing that. But you really first should know if you're asking in regards to having stones, are those stones related to oxalate? Because they could be uric acid stones. So you want to make sure you know that first. And then there's certain foods that are foods and drinks that are higher in oxalate, and there's certain ways you can reduce that oxalate. Again, it will probably be another really good presentation if we want to add that to our future topics. But in the meantime, I would look for a list online.
Very good. And this is probably our last question for your session. What are your thoughts about taking Imodium daily?
Yeah, I don't necessarily want to prescribe that, and I'm not a provider, so I can't. I would find out why you want to take it. Really, ask yourself why, and if you can manage your diet and your output with looking at the food you're eating and the fluids you're drinking versus taking a medication, that's my personal way of moving forward. I would be hesitant to say you should take Imodium daily, but again, I don't know your whole health history and I'm not your provider. But again, look at some of the food options first.
Well, there have been some really good questions, haven't there, Judy? And we can always learn a lot more. I certainly learned a lot of stuff tonight too, and I appreciate it so much. Thanks for being with us, and hang in there in case there's any more nutrition questions that come up. And now for our third speaker of the night, I'm so looking forward to having you all meet Colin Jarvis. I had the privilege of hearing Colin speak a few years back at the United Ostomy Association National Conference. And if, by the way, you've never been to one, you're really missing something. Next year, in August 2022, we will be in Houston for our national conference, and we sure hope you can join us. I know that there's a lot of people that can't always go to affiliated support groups, and so there's many individual memberships through the United Ostomy Association of America too. So there's so many ways to find out more information about that. Make sure you're registered, and you can sign up to get the e-newsletter when you're a member. So that's a little benefit. But back to Colin. That's who I am. I just get off track sometimes. Colin was just 20 years old when he was diagnosed with ulcerative colitis. He was competing as a long-distance runner at UC Berkeley and was an Olympic hopeful. As many of you have experienced, his illness got to a point where running was no longer an option. Not only that, he had to leave school and have surgery for an ileostomy. Despite being apprehensive about running with an ostomy, he challenged himself and found out he could still run as well, if not better than when he was sick. I hope he tells us a story about running in Edmonton, because that's really amazing. I don't know if he's going to. Well, just a cliffhanger. He wanted to inspire others to help them navigate their own way back to health. And eventually he got involved with Stealth Belt and is their vice president, so he can help people live active and fulfilling lives. We got to love that. So welcome, Colin. Take it away.
Thanks, Brenda. And
You're welcome.
Awesome introduction. I appreciate it as always. And thanks for everybody else for tuning in. I'm going to go ahead and share my screen here just to help guide my presentation. But all right. Can everyone see it? There we go. So as she mentioned, my presentation will be on exercise and physical activity. Unlike Dr. Fern and our nurse Judy, I am not a clinician of any kind. So all of the advice that I'll be sharing is really going to be coming more from an anecdotal perspective, and just having had an ostomy now for 7 years and living an extremely active lifestyle. Brenda's touched on it a little bit, but I am a very avid long distance runner, training for marathons right now, but I've do a number of other activities like rock climbing, surfing, weightlifting, you name it. And I think in the beginning, when I first had my ostomy, I shared a lot of the common concerns that come along with the surgeries and how that will play out, and those questions that many people have. And so I'm hoping that I'll be able to answer some of those for you today. And if I don't, you can ask them to me towards the end of the presentation, and I'll do my best at that point. But okay, so to start, I wanted to talk most specifically about the first 3-ish months. And I say 3-ish because I just want to make it clear that it's really just generally the first period of time once you're recovering from having surgery, when your scars are healing up, when you're getting out of the hospital and starting to feel healthy again, and really just trying to get your bearings under you again and figure out how to live life with an ostomy. And I broke it down into 3 general categories that you can see here. And the first is to find your appliance setup. And what I mean by that is to find the combination of different appliances and support that you need to, as much as possible, reduce the chances of leakage and skin irritation. I know that in my experience that leakage and skin irritation were things that I struggled with a lot, especially in those first couple months. And I think that was largely because I was given a certain set of things straight out of the hospital, and I didn't immediately try to switch those out and figure out what works for me. And what actually ended up happening was my skin got really irritated, almost in a perfect square right around the wafer that I was using. And, you know, I washed my skin thoroughly with the right kinds of soaps with no added scents. And, you know, I could not figure out for the life of me why this was happening. And eventually I got to the point where I started trying some other products, and I found that I was allergic to one of the skin preps that I was using. And it wasn't so allergic that I could just use it once and it would flare up. So it wasn't immediately obvious. But as I started rotating around and trying different appliances, trying different adhesives, I was able to kind of zero in on the things that worked best for my particular situation, and what my skin could handle. Because I think everybody has a slightly different reaction to these adhesives, and each company has, like Hollister, Convatec, Coloplast, etc. They're all going to have different types of adhesives and different formulas that go into those pastes. And it's really worth checking out what all the different options are, because, you know, you might have something that's working fine for you now, but if you don't actually go through the steps early on or at any point to try and see what works best, then you might actually be missing out. And if you're somebody who has a permanent ostomy, in my opinion, I think it's in everyone's best interest to find what is the best possible combination of things that I can use to give me the best possible overall experience with an ostomy. And I think that that also extends to support garments as well. And I'll talk a little bit more about support garments later on, but I just wanted to mention that if you're looking at getting physically active again, there are a large range of benefits that a support garment can provide, and that is extends beyond just the risks for hernias. But like I said, I'll touch on that in a little bit more detail here in a minute. But for the second point that I wanted to reiterate, and I think both of our first two presenters did a really good job of going through a lot of these, but I just wanted to kind of share my experience with the importance of diet and hydration, in particular when it comes to being active again. Because as somebody who runs long distances, and I'm in California, so it can get pretty hot where I live a lot of times of the year. And so I sweat a lot. And in order to be able to do the things that I want to do and go out for these runs that are multiple hours long and not worry about issues that are a lot more common amongst those of us who have ostomies, like dehydration and deficits in the types of vitamins and minerals that we're getting from our food, I had to do a lot of research and learned from people like Dr. Fern and Judy that have been in this space for a long time, and just understand what is it that I need and how can I make sure that my body's best set up to receive what I'm giving it. And one of the, I like to use an analogy whenever I talk about hydration in particular, is and this is something I learned from as an athlete well before I had even gotten sick. It was kind of drilled into us when I was on my university's team, and being hydrated when you're an athlete is just incredibly important. So it was an easy transition. But I like to think of the body as kind of like a battery. And if you've ever had like your cell phone or some device that you're using and the battery's getting close to almost zero, you're in that last like 5 or 10%. If you notice, when you plug that device into its charger, it will actually gain back a lot more of the battery life a lot quicker. Like you'll get up to 50 or 60% really fast. And as you approach 100% full battery life, it's going to slow down. It takes longer and longer to maximize the full charge of the battery. And for our bodies, when it comes to hydration, it works very much in a similar way. Dr. Fern was talking about how when we want to stay between that 75 and 100% of hydration, that range. But once you've fallen out of that 75% threshold, it can be a lot more challenging to kind of bridge that gap to get back there. And so the best way of approaching it, beyond just making sure that you've got the right types of fluids and the right levels of electrolytes, using your oral rehydration solutions or whatever it is that agrees with your body the best, it's really important to think about the way that you're actually taking in that water and the timing of it. And so what I mean by that is, if you have a certain amount of water that you're supposed to drink in a given period of time, so like each day, I think that 8 cups of water is like at least an old adage for how much water you should drink. I don't know if that's the actual recommended daily value anymore, but let's say it's 8 glasses of water. If you were to wake up in the morning and just slug back 8 glasses of water right after another, you're not going to be helping yourself hydrate. And in fact, like Dr. Fern mentioned a few times, you'll actually dilute your body of the types of electrolytes that you need to absorb it properly, and even set yourself further back. So the best way to actually do it is to make sure that you've got something around you all the time. Usually I have my water bottle with me, but when I'm at my desk, I've got just a mason jar of some electrolyte fluids. And I've built the habit over the course of, decades, from before I was sick, but sipping constantly and small sips throughout the day. So you're trying to just put the right amount of water or liquids into your body at the proper amount of intervals throughout the day so that you get the best bang for your buck in the water that you're drinking. And I found that actually has made a really big difference. And when it comes specifically to preparing for a really big effort, like if I were going to run a marathon, my hydration process building towards that big effort starts many days or even weeks in advance. It's not something that you can just rehydrate in a matter of a couple minutes, because you go back to that phone or battery recharging idea, and you have to think, if I'm going to get to that 100%, I need to make sure that I leave enough time and I do it properly to achieve that goal that I have. So I like to always mention that when it comes to hydration, and just play off of the great information we've heard so far. And then as a second point, as far as diet's concerned, the one thing that I would add, and this is, again, it was kind of already touched on, and I think both Dr. Fern and Judy recommended that you keep a journal of the types of food that you're eating, and so that you've got a consistent record of like how your body responds to what you're putting into it. And I agree with that 100%. It's something that I did early on when I was first adjusting to having an ostomy, and I was trying to figure out, like, what can I eat? How often can I eat it? What are the things that I definitely can't eat and why? And so keeping notes of those things can be really helpful. And so what I would recommend in particular, if you're interested in doing this, would be to set up your journal in a way, and your diet in a way, that you've got a baseline of all of your foods within a week period that you know you can tolerate. So these are your really safe, low residue type foods that you're probably eating directly after surgery. And then each week you add in one new experimental food at a time, and make sure that you give yourself a day or two before trying any other new food. And that gives you enough time to journal about what that food is that was your experimental food, and to see, did it have any adverse effects? And if not, was it because I chewed it really well? Was I being cognizant of that? Or was it, actually my digestive system just didn't have a problem with it, and it seems like whatever that experimental food is back on the menu. And as you kind of check the boxes and go down, you'll find that as long as you're pretty cognizant of the way in which you're eating things, that most foods should be available to you again. Of course, don't take that as a blanket statement, where some people, like myself, I have no problem eating raw vegetables and salads, and I eat quite a bit of like raw almonds and cashews and pistachios. But that's also because I hydrate really, really well, and I chew when I'm eating those types of foods that don't always get broken down in your digestive system as easily. I make sure that I chew it like crazy. And so it's basically like a paste in my mouth before I'm swallowing. So that's why I'm able to tolerate those things. And I did all of those journaling within those first couple months after having surgery, when I was trying to figure things out. And so when it comes to getting active and exercising again, these are just really critical points. So I think it was a great segue to have both the hydration and the diet portions of the presentation lead into I think the next step of getting active again. And so that's kind of the first 3 months that I was talking about, and like some of the things that you should be focused on there. But as you kind of nail down those baseline things, the third thing that you want to focus on is laying the foundations for yourself with physical therapy and re-strengthening your core, and having the type of mobility and body control that you need to be able to exercise effectively and safely to prevent hernias, and to just get back to living an active and exciting life again. And, I think the theme with a lot of what we're talking about today, and anytime you're dealing with recovery from a major surgery of any kind, is to take things really slow. And that when you have surgery, your core is going to be especially vulnerable. And I think I may have this on another slide here, but the likelihood of developing a hernia is highest in the first 8 months after surgery. And I think I saw a stat, and don't quote me on this, but something like 60 to 70% of people who have an ostomy will develop some form of a hernia throughout their experience with that ostomy. And the bulk of those hernias will form in the first 8 months. So that tells you a few things. And I think the most important thing is that you need to be really cognizant of how hernias form and what you can do to help prevent that from happening. And so when I say that you need to focus on rebuilding your core strength, I think it's helpful to understand how and why people who have ostomies are particularly more likely to have a less core strength than even just the typical person. Because if you think about what most of us have been through with having an ostomy, you're going to start with, if you are sick for a long time, you've got IBD and your stomach is in constant pain, one of the things that is kind of a natural reflex is to kind of hunch forward and to kind of to lean forward and kind of protect that area that's in pain and feeling vulnerable. And so that kind of reduces the need for those core muscles to keep you upright and engaged. So that's an element to consider. And then if you're also really sick, there's a good chance that you're not keeping up with a regular exercise routine. You're more focused on just not being in pain all the time. And so you're not working those muscles as frequently as somebody who is just healthy. And now you add those two general factors to the idea that now you've got incisions in your abdominal wall. You have to, those incisions and those scars need to heal. And no matter how much strengthening you do, because you've had those incisions, you're always going to have a slightly higher risk of developing a hernia purely by the fact that you've got an ostomy. And I don't want that to sound overly bleak, but it is a reality that we need to face and be aware of. And as long as you kind of approach it with a multifaceted, if you take it from a multifaceted approach for prevention of hernias, then you should be able to transition back to being active again and living a life full of exercise if that's what you want to do. So some specific things that I would recommend for rebuilding the core strength and laying those early foundations would be to first and foremost, if it's possible to you, talk to a physical therapist who focuses in abdominal recovery and pelvic floor strengthening. And there's actually a lot of PTs out there who have this specialty, because the recovery for a lot of women who've had C-sections is actually pretty similar to the types of recovery that we'll do with an ostomy. So if you look for a PT, and it's worth asking them, do you have experience in abdominal strength recovery and pelvic floor? Because those are the types of workouts that you're going to need to do to rebuild your core strength to a point where you can be comfortable and safe when you take on more intense activities like running or weightlifting later on down the line. And so I always recommend talk to a good PT, because beyond just showing you what types of movements that you can do safely, because you can go on YouTube and find a bunch of stuff out there with postnatal exercises, but having somebody who can show you exactly how to engage your muscles and how to move in those movements properly, you're going to have a lot more success with all of that work that you put in when you're doing it properly. I like to think of the Michael Jordan quote, and I might butcher it here, but it's something like, I don't even remember exactly what it was, but he says something along the lines of, you shouldn't practice taking 10,000 bad shots, because then you'll just get really good at doing something poorly. You want to make sure that your form for all of these movements is as good as possible, so that when you do those repetitions, you're doing it in the right way, and that will pay dividends for you later on. So if possible, talk to that PT, or at the very least, just do your research to make sure you understand how your body is supposed to be moving and working together. And so to kind of dive a little even further into the prevention of a hernia and how to safely return to physical activity, because I think hernia prevention is often one of the biggest concerns, is a kind of the next step in the core re-strengthening. Once you've gotten through those first couple months and you've done all of the PT and you've got your core ready and your doctor gives you the green light and says, okay, you can start doing some light exercises now. Great. So what should you be focused on? And what I like to tell people, and I think this is just a general tip that everybody can benefit from, is to really work on your posture and your functional movement. And that in particular is so important for people with ostomies, because when we have all of that weakness in our core, it can cause us to have particularly bad posture. And there is a bit of an epidemic of bad posture in our society in general right now, just because so many of our jobs require us sitting at a desk all day, and just the level of activity that the average person has throughout their day is not very high. A lot of times that can result in going in having poor posture. And, you know, I when I've had my surgery, it had been 8 or 9 months, I think, since I was diagnosed. I had a pretty short period of time where I was actually sick. But during that time, I spent so much time being inactive, not using my core, and then also just like feeling really down and depressed. And so I kind of naturally hunched forward. And when I went to the doctor and he measured me, I had shrunk like 1.5 inches. And I was like, wait, hold on. No, I'm taller than that. And they said, nope, take a look. And I looked, and sure enough, I was 1.5 inches shorter than I had been when I measured myself a year ago. And that was purely because over the course of that year where I was sick, my posture, and then the surgery, of course, my posture took a hit. And, you know, I didn't feel it or notice it until that happened. And then I started thinking about like, wow, that's such a big change in the way my body moves, and it's subconscious. I wonder what else that's doing. And as I kind of delved into that rabbit hole, both from doing research on other studies that have been done, and also just kind of conducting my own experiments, I actually found that when you have good posture with an ostomy, you're going to experience less leaks. And that this is just an added benefit of fixing it. And it helps when you're exercising to know that you're less likely to have a leak. But if you think about the way your body is situated, when you have proper posture and you're moving in a functional way, that the part of your abdomen where the ostomy actually attaches is not going to bend as much, and it's not going to need that adhesive to stretch in order to stay applied to your body as often. And that reduces the chances of leaks. So I actually found over that course of that first year or so that it took me to kind of fix my posture again, that as that happened, the leaks became less and less likely because I wasn't putting in as much strain on the way that the appliance was attached to my body. And then, I mean, back to the perspective of how does this actually help you with an ostomy to get back to being active and preventing hernias? I like to, I think in terms of examples a lot and kind of tying similar ideas together. But when I think of having good posture and functional movement, I think of the people who are the very best at it in the world. And those are Olympic weightlifters. So, you know, those really strong, often kind of short people that can put like insane amounts of weight above their heads. And, you know, they're able to do that without injuring themselves. And, you know, I don't think that there's a whole lot of people who have ostomies that are looking to be Olympic weightlifters necessarily, but there are lessons to be learned from that, because anybody can get a hernia if they put strain on their abdomen and cause a tear in that abdominal wall. I mean, it does happen, but the people at the very highest level are moving their bodies in a way that's functional enough that it's all working the way that it's meant to. And when they do those heavy lifts, there's no strain happening on their body in a way that it's not meant to be able to handle it. And so the more that you and I, as people with ostomies, the more we are able to integrate that type of movement and having that good posture, the less likely we are to then develop a hernia later on down the line. And so this actually, I think, ties back to when you're trying to find a physical therapist, another good like keyword or thing to look for in that therapist's resume is, do they have any background with functional movement? And I think that any good physical therapist will know exactly what you mean when you ask for that. And somebody who specializes in functional movement will help you understand like how to position your body, how to engage the parts of your core that aren't necessarily weak, but aren't working the way that they're supposed to. And if you can do that, your posture, you'll find, will start to improve. And the range of benefits that come with that extend far beyond just the reduced risk of a hernia. But that happens to be, I think, the biggest benefit. And then as far as getting back to being active, I said that I'd touch a little bit more on support garments here. And there have been a lot of studies out there that I've read. And as somebody who works with stealth belts and we make these support garments, I've taken the time to learn a lot about this. And what I've been able to glean from my research is that there is no silver bullet for preventing a hernia. And I think a lot of times people will say, or will get the impression that some type of hernia support belt is going to just shield them from getting a hernia. And that's frankly just not the case. In that I've never seen a research study that actually shows that it's effective at preventing it. The best that it said was an added support garment with intra-abdominal pressure may reduce the likelihood of a hernia. And so that, I mean, it's a little frustrating to hear because, we'd love to have a simple solution. And as somebody who sells the belts, I'd love to be able to tell you that in full confidence. But the fact is that most support garments are actually for the management of a pre-existing hernia. So if you've already developed a hernia and you need to stop it from getting worse, that's when a support garment can be very effective and is certainly recommended. But I think that having a support garment, even if you don't have a hernia, is still very much worth doing if you want to get active again for a number of reasons. One is that it's going to help you support the weight of the appliance. So even if it fills up, if you're out and about, you're not going to have that tugging on the appliance itself. So it will help reduce the irritation that you feel. And then also, if you're moving around a lot, you want something that's going to help hold the bag against your body. That's going to make it a lot more comfortable. And then from I think more of a psychological perspective, it's just nice to have something that's applying a little pressure that's going to help reduce the chances of a leak, and also just aesthetically not look so medical. Because I know that for me, the ostomy appliances, once I figured out the right combination of things, the appliances functionally worked extremely well, but an ostomy bag just looks so clinical. And that was a big hurdle for me psychologically to get past. And so the introduction of a support garment, and in my case, the stealth belt, really helped me bridge that gap and started giving me the confidence that I needed to get back out there and start trying to run again and to do those things that mean so much to me in being active. And then I've already kind of touched on this, but one of I think it's worth mentioning that according to Johns Hopkins University, some of the leading risk factors for hernias are older age, which of course just comes with deteriorating strength, and you no longer have the same regenerative abilities at that age. So that's, I think, a pretty natural assumption. But also increased BMI and increased waist circumference in an activity. And so I think this kind of all wraps up into one thing, where when I was talking about having a multifaceted approach to preventing hernias, that you need to consider your diet and your health as your body as a very serious factor in the likelihood of developing a hernia or not. And so the more you can adjust your diet early on and be regimented about your journaling and figuring out like which foods can I eat, what's a good routine for me, that's also going to have an impact on the reduction of hernias, and so being the ability to get active again. So I think that that's really important. And even just going out for things as simple as daily walks can do so much for building up your strength in your core and in general. So just having a consistent regimen of light activity as a baseline can make all the world of difference. And it's going to be, like I said, that foundation for allowing you to get back to being active and exercising again safely. Okay. And then finally, when it comes to getting active again, I think the last thing that is important to consider is the psychological component. And I've kind of come up with this, what I call the 3P approach. And that's to have patience, perspective, and perseverance. And the way I break that down, and I have used this in my own life, is to really have patience with yourself. And Judy touched on this as well. You have to be kind to yourself and just understand what your body's gone through and know that there's going to be setbacks, and know that you're going to get frustrated and that that's okay. And you just understand that you're going to have limits and that your body is not going to be the same as it was before you had surgery for a while. And that, you know, that takes a large degree of patience, because we feel more healthy now with an ostomy, but you know, there's all these seeming roadblocks. It can just seem like an endless line of things that you have to go through to get back. And, you know, it will happen. Just make sure not to rush it, because you'd rather have an extra few months to get back to what you want to be doing than to try and rush it and then give yourself a hernia and set yourself back again even further. And then from a perspective, the perspective is all about the way that you consider your situation. And I think that you can look at any given situation for the positives or for the negatives. And if you focus on the negatives, then your interpretation of your situation will be negative. And so even if there aren't as many positives as there are negatives, it's still better to always focus on those positives that you do have, you know? So you conceptualize having an ostomy as a second chance to really get out there and live your life again. And it's a wake-up call, because it helps remind us all that what we're experiencing right now and being alive is not guaranteed. And there is no, we have no predictability. And so take advantage of those moments and seek the good in every situation. And then finally is the perseverance. And that goes back to understanding that you're going to have setbacks and frustrations. You're going to have leaks. Your fitness is going to lack. Things are probably going to take longer than you would expect them to, but you're playing the long game, and you need to be able to just kind of get through that and, you know, use your patience and perspective as tools to be more perseverant in your pursuit to getting back to being active, or just generally living a happier and healthier life. So with that, I will turn it over to our Q&A section. And yeah.
Thank you, Colin. That was a great talk. There's a lot of questions coming through. And I want to tell you that I'm sitting up just a little bit taller since you started talking about, you know, posture, and I'm getting older, so I have to really be careful.
I've got another tip for you real quick, actually,
What's
Brenda.
that?
Check out this chair. I can only sit in it at like a couple hours at a time because it's kind of tiresome, but it's a chair where your knees sit here.
Oh.
Back. So you'll see that when I sit down, it forces me to sit upright.
Oh,
so
nice.
There's, you know,
Does that work with people that have had 2 knees replaced? Do you think it works good?
I'm sure.
It's
your shins are really what's on the seat. So.
Oh, yes, and they are plentiful. Okay, so thank you very much, Colin, for that advice, personal advice. Appreciate it. One of the questions was, you addressed hernias, which we really appreciate, but someone asked if they had a prolapse, stoma, and a hernia already. Is there anything we can do for that? Any advice about that? And that's from Chris Owen.
So I mean, that's a tough situation. I'm not a clinician, so take my advice with that large grain of salt. But in my experience with people who've had prolapses that I've spoken with, a lot of times you want some type of pressure that goes over top of the prolapse so that it can be held in, and that goes the same for the hernia. So I would say that you definitely need to find some kind of support garment that's going to work for you to do both of those things. Because I know that a lot of times prolapses will kind of come out, prolapse, and then they'll recede back in depending on if you're laying down, and the hernia kind of works similarly. So when your prolapse stoma has come back into your body as much as it does, and you're laying down so your hernia is down, you want to put your belt on at that point where it's got enough intra-abdominal pressure to hold both of those things in. But if you have more questions, I think that's really better served for your particular doctor, because that's a tough one.
This might be one of those too, but Eyes on You said, I'm not allowed to drink water due to having SIADH, which I found out means syndrome of inappropriate antidiuretic hormone secretion. I don't know if you know anything about that, but he has a new ostomy. Do you have any suggestions of fluids?
Yeah,
I mean, to drink water.
I would have to do some I've never heard of that. I'd have to do some research, because SIADH, to not have water, because pretty much all the fluids that you drink, whether it's some type of electrolyte fluid or your coffee, your tea, I mean, the base is water. So I'm not sure I understand what it is that you'd be drinking. Oh, Dr. Rob Fern, he says he can jump in. Please do.
Okay, yeah, let's hear about that, Dr. Fern.
No, I mean, it's actually, that's a really challenging situation, because when you have SIADH, you're effectively retaining too much fluid in the body. So the more you drink, the more you can dilute the salt and cause a low salt level. In some ways, it will be protecting you from some of the dehydration issues that you're at risk of. So really what you need to do is follow the instructions you've been given. There's some very good and well-established treatments for SIADH that partly involve water restriction and partly involve the medications that normalize the hormone, and obviously identifying the underlying cause of it, which may be treatable in itself. Where it's relevant here, I think, is clearly if you are planning to exercise, assuming you have an ostomy as well, and you have SIADH, then that's a very complex situation you definitely need to discuss with your medical team.
Yes, I think so. Can you stay on too, just in case there's another question here?
Of course.
How can I guide my 3-year-old with an ileostomy since birth? She drinks Cerolite 70 in addition to formula. Should I offer beverages every hour?
So I'm not a pediatric gastroenterologist. Some of the sort of calculations around fluid requirements for kids are based on the same numbers, but are slightly more complicated, just because the amount of fluid in different compartments of the body is different. So I don't want to sound like a cop-out, but I'm going to suggest that one really should be directed back to the team.
Seems like every case is so unique that you need to do that often.
Absolutely.
Barbara Jordan asked if you can give tips on emptying your pouch while hiking, sup, kayak, group raft trip in nature when bathrooms are not around. Have you had to go through that with long distance marathon running?
So much.
Yeah, tell us about it.
I mean, I would say that happens to me on probably at least a weekly basis, where I'll be out and I don't have a bathroom immediately available and I've got a full bag. And I mean, sometimes I can, if I'm out in the middle of the streets and it's not somewhere that would be appropriate to just go to the bathroom, then I just have to deal with it. But if I'm out on the trails or out in the woods, I mean, a lot of times what I'll do is because I use the stealth belt, which you can see back behind me, and there's a zippered pouch compartment where the bag actually sits. But when I go out for a long one and I know I'm going to be out there for 2 to 3 hours, I'll take a little Ziploc bag and then just have some biodegradable toilet paper in there with me, so that if that does happen, I've got easy access to it and I can just duck off the side of the trail. And I mean, as a runner and in this world, and the hiking and any outdoors, is don't feel embarrassed about doing that, because even people that don't have ostomies will do that all the time. Just, make sure that you go far enough off the trail and use biodegradable toilet paper, and, don't litter. I'd say that's pretty much, that's it.
Don't litter. Yes, that's a good point too. Well, there's some more questions, but we really are running out of time, Colin. This has been such a great half hour listening to you talk, and I appreciate it. And I'm sure people can get a hold of you at Stealth Belt if they need some more questions about that in particular.
Yeah, and I'm on social media too. So if anybody has particular questions that they want to ask me, feel free to just send me a message. I'm usually pretty good about responding to those.
That is so great. Thank you for being with us. We really appreciate it.
Yeah,
and we've got just a couple more minutes left with our last speaker, and that is Molly Atwater. It's a final but important message. She's our volunteer director of young adult outreach, and quite an awesome individual, I must say. You may have seen her on the cover of the Phoenix magazine not too long ago, talking about her own amazing story. She has chronicled her life with an ostomy, and you can find her on Facebook as Molly Ali Ostomy. She underwent ileostomy surgery in 2017 after struggling with chronic constipation, a symptom of a genetic disorder. She's a frequent speaker of ostomy support groups, and we love having her on our board. Molly will present our mental health moments for each session that we have. Molly, welcome.
Thank you
so much.
Thank you. I'm so excited. I mean, everybody else has been so incredible. So I feel like I'm pitching in the last minute, but thanks for including me. So one of the things that we were talking about when it came to the Ostomy Academy was the fact that so many of these topics revolve around the mental health impacts of having an ostomy. And I know that immediately after I had ostomy surgery almost 4 years ago, the physical change was huge, but honestly, just as huge, if not more so, was the mental and emotional change. So each time we do one of these Ostomy Academies, I'm going to pop on really quick to just talk a little bit about how our mental health can be impacted by the topics that were shared today. So just a little summary of all the things that that hydration and diet and exercise can really help to do for those of us with ostomies in terms of our mental and emotional well-being. So when it comes to hydration, we may not be quite as used to drinking as much fluid or the types of fluids that we're supposed to. So one of the things that we can do as ostomates is do a little bit of trial and error and see what we like to drink, what we don't like to drink. Luckily, there are plenty of electrolyte supplements out there that what one person loves, one person may say, not quite as much. So it's worth it to go ahead and experiment with what you do enjoy and what you can fully incorporate into your new normal. When it comes to diet, maybe your ostomy has completely broadened your horizons in terms of food, and that is so exciting. So it could be a great blessing to all of a sudden be able to eat those vegetables that you couldn't eat before, or go out to a dinner at a fancy steakhouse and get a meal that you may not have been able to digest with your previous conditions. If you're somebody like me who experiences tons of blockages, your diet might be a little bit more restrictive, and that can be really frustrating and saddening. So what I've tried to do over the course of the last 3 or 4 years with my ostomy is find those foods that I don't mind eating every single day. So everybody makes fun of me, but I'm a huge fan of Cheerios. They don't block my stoma. They don't give me any sort of obstruction. So I've got 4 boxes in the pantry right now. And every time I have one, it may not be the most exciting thing, but I try to have a moment of gratitude that what I'm putting into my body isn't going to hurt me. And I actually don't mind enjoying it. So just those little tweaks and mindfulness moments to recognize what your body is capable of doing and appreciating what your body is doing for you. In terms of exercise, there are so many ways to keep your body moving. You could be a super athlete like Colin and go out and run some marathons, or you could just be your average neighborhood walker, and that is absolutely fine. I think the most important thing that we heard from everyone here, especially Colin, was that patience and perseverance and just finding something that you enjoy and sticking with it. And giving yourself the grace to have that growth period through your experience. One of the things that I've learned through my journey as an ostomate is that there's no right or wrong way to approach your mental health struggles with an ostomy. Surrounding yourself with a team, whether that's your family, whether that's your friends, whether that's your partner, whether that is a clinical therapist or your doctor staff, finding someone who you can fully trust and share those maybe more difficult emotions, finding somebody like that is hugely important in the acceptance of your new normal. That's a phrase that we've all heard so much now with the COVID-19 pandemic, but I think ostomates really know when you go into ostomy surgery, you have to find your new normal, and it can be frustrating and it can be maddening, and there are days when things seem really, really hard, but it's important to recognize that all of those emotions are valid, all of those emotions deserve to be felt, and that there are good things to look forward to every single day. So just in summary, be kind to yourself, to take a phrase from Judy, and give yourself the space to feel whatever you need to feel, and find the little pieces of good in every day as an ostomate, bag and all. Back to you, Brenda.
Thank you, Molly. That was inspirational. And also, I feel like going to have some Cheerios for dinner now, I have to tell you. I wasn't planning on that, but it sounds delicious. It sounds. I want everyone to know about our next session. It's going to be held early September, and you'll probably get a notice about it, but you can also check at the website at ostomy.org/ostomy-academy. And then you can find out more about what the next one is on. And it'll fly by before you know it. Didn't this 2 hours fly by fast? I want to thank UOAA for all the efforts in getting this together, and especially 11 Health for powering us through this. All the speakers that took their time and volunteered their time to be here tonight and gave us all that great information. I have learned so much. And also for the people that really hung in there with us tonight and asked the good questions. We needed those questions to really make it a great event. So we are honored by your presence tonight, and we want to thank you for being here. Good night, everybody.